Hello, and thank you for joining today's event, our 5th annual Current and Future State of Interoperability. I'm Carol Flagg of Andrews Media Network and Healthcare Now Radio. We appreciate your time today. It's been an eventful year for interoperability since our last panel discussion with the finalization and publication of the CMS Interoperability and Patient Access Rule and the ONC Cures Act Rule that shepherds in information blocking. Amidst the ongoing pandemic, these rules move forward, impacting healthcare stakeholders starting in 2021. Our all-star lineup of panelists, along with our moderator, will discuss where the industry is headed amidst the backdrop of government regulations and COVID. This event is made possible by the support of Consensus, a brand of J2 cloud services. Founded in 1995, J2 is an award-winning leading provider of internet services through its 2 divisions, Business Cloud Services and Digital Media. Learn more at www.consensus.com. And now I'd like to introduce our moderator for today's event. Matt Fisher is a partner at the prestigious law firm Myrick O'Connell and is also the host of Healthcare Du Jour on our Healthcare Now radio station. Matt's health law practice includes advising clients with regulatory, privacy, security, fraud, abuse, and compliance issues, and he works with all types of clinicians within the healthcare system, including hospitals, physician groups, skilled nursing facilities, home health agencies, and more. Matt also advises digital health and health information technology companies from startups to mature companies. And now to our panelists. Dave Cassel is the Executive Director of Care Quality, a nonprofit organization that provides a national level consensus-built common interoperability framework to enable exchange between and among health data sharing networks. Dave has worked for over 20 years in health IT, creating a national reputation as an expert in health information exchange. As Executive Director of Care Quality, Dave is responsible for the interoperability framework, which enables health data sharing across and among different types of networks. Under his leadership, the national level trusted exchange framework was first implemented in July 2016 and has rapidly grown to include more than 600,000 providers across more than 1,700 hospitals and 40,000 clinics, currently sharing more than 80 million documents a month. Jeff Coughlin is the Senior Director of Federal and State Affairs for HIMSS, where he leads HIMSS' effort to build stronger relationships with federal agencies and facilitates the building of a nationwide network of advocates for state-based initiatives. Before joining HIMSS, Jeff was the team leader for corporate accounts at the Marwood Group. He also spent several years in the healthcare nonprofit advocacy world, where he led efforts in policy development, directed outreach to Congress and executive branch agencies, built advocacy coalitions, and created robust grassroots networks. He also worked for HSS as part of the team responsible for the development, implementation, and management of the Government Performance and Results Act within the department. Chris Emper is the president of Emper Healthcare Advisors, a DC firm specializing in helping healthcare providers and technology companies navigate and comply with complex regulations and value-based reimbursement models. Prior to forming Emper Healthcare Advisors in 2016, he served as vice president of government affairs at NextGen Healthcare and was chair of the EHRA Public Policy Committee. He also served as chair of the HIMSS Government Relations Roundtable from 2016 to 2019. Prior to joining NextGen Healthcare in 2013, Chris served as domestic policy advisor for former Massachusetts Governor Mitt Romney's 2012 presidential campaign, where he advised the campaign on policy issues including healthcare, technology, and innovation. And completing our panel today is John Nebergall, Vice President and General Manager at J2 Global. John is an accomplished senior executive with over 30 years of operating experience in the compliance space, with a particular emphasis in health IT. Prior to joining J2, he held several executive level positions, including Senior Vice President, Global Client Services and Solutions Adoption at Orion Health, Senior VP in Client Services at Allscripts, and Senior VP for Credit Solutions at Experian Information Services. Most recently, John served as the General Manager of DemandForce, a Bay Area cloud software company serving the healthcare, dental, chiropractic, and lifestyle industries, where he drove all aspects of this business. He is also an adjunct professor of clinical informatics at the University of Illinois, Chicago. Just a couple more items before we begin. First, a copy of the recording of this event will be sent out to you in the next 48 hours. Also, you can use the Zoom tools in your dashboard to individually adjust your view. And now I'm going to turn the panel over to Matt Fisher and for our conversation. Matt, you can take it away.
Well, welcome everyone, and thank you for joining. It's looking forward to yet another one of these discussions. It's, as Carol said in the introduction, hopefully we've seen a lot of development in the past year since the last panel. And while theoretically there's a final or final rules that have been published for interoperability, the tea leaves seem to say that those are going to get delayed again. But hopefully that's not going to overly delay or impact efforts for actual organizational level change. So before we kind of dive into the real part of the discussion, I want to give each of the panelists a chance to give a little bit more of an introduction and to give a kind of an opening statement when it comes to where they see interoperability currently resting. So I'm just going to go based on how I'm seeing the names pop up, which I think actually ends up being in the reverse order of how Carol did the initial introductions. So John, you're up first.
Great, thanks, Matt. As you can see, I'm going to be joining the panel nautically from the sailboat where I live, and that's how we shelter in place. So it's okay. I think as a practical position, I start to think about the new interoperability rule as a journey to get to a place that it puts all of healthcare in a much better information sharing structure. The thing that I think we have to all think about is the path to get there. Throwing a switch, as we have seen in the past, is never going to be the answer. And when you think about somewhere around 75%, and I think that was Direct Trust's estimate, 75% of all secure information sharing that happens within healthcare happens via fax protocol. We have to think about this from a pragmatic point of view and say, look, we've got a starting place, we've got a finishing place where we want to get to, but let's understand how to take the steps to get folks off of paper onto an electronic system and ultimately into a data sharing environment that is going to benefit all of healthcare. And that's really the journey is what we are most interested in thinking about and working towards.
John, thank you for those initial thoughts. Chris, how about you?
Well, thank you very much for having me here today. Just to add a little bit to my introduction, and so everyone knows my background and the perspective I'll be speaking from today, formerly worked in the EMR industry and was Vice President of Government Affairs at NextGen Healthcare, and have since, a few years ago, started my own boutique advisory and consulting services firm, where I work with not only IT vendors, but also the ambulatory community on the provider side and physician practices around complying with and implementing a lot of these different programs coming from the government. And from that perspective, I think it's a very exciting but yet a very challenging time, because we are at a point where there's never been more work been done and resources available from the private sector side of things, care quality being one of those initiatives, many others as well. But at the same time, the government is pushing forward a major initiative that's really been over 5 years in the making. I mean, the Cures Act law passed in December of 2016. We just saw the final rules this year, and we're looking at implementation over the course of the next few years. And for many in the physician community and in the IT community, we're just trying to figure out exactly what these rules mean, what we have to do, and ultimately how we'll comply with this. And as Matt, as you mentioned, with another potential delay, as the rules have already been finalized this year and then announced enforcement discretion on top of that, I think that'll just add to the confusion.
Thank you, Chris. Jeff, would you like to give your introduction now?
Thanks, Matt. And I completely agree with everything that Chris and John just said. So, the only thing that I will add is I think that organizations are moving as quickly as possible now to figure out how to implement these new rules and kind of embody all of the work that ONC and CMS have really put forward to try to facilitate more patient access to their data. I know we'll get into some more specifics. The final point that I will make too is that I think that there is a lot of work that needs to be done in terms of how these rules intersect with other kind of regulatory vehicles, whether they be HIPAA or a broader privacy regime, et cetera. I think that's something that I know organizations are in the process of trying to figure out, and I hope we can get into some discussions about that today.
Jeff, I think you're doing a good job of previewing some of the topics that we'll definitely need to explore, because it's, as you said, the intersection with other regulations. I'm already having that come up with clients asking those questions. So it's, something that will, does have a lot of implications. But Dave, I'll turn it over to you for the last introduction.
Sure, thanks. So I get the last word, I suppose. Broadly speaking, I think the others here have covered it reasonably well. I would agree with Jeff that I think people are really digging in and making a good faith effort to prepare for compliance. We'll talk more obviously about the impact of the enforcement delays and exactly what that's going to mean. And I think in some ways it's probably going to end up being overall beneficial in that people really do need a little bit more time to deal with all of these requirements. And the fact that there are so many requirements, these are such broad rules and introduce so many different elements that have to be analyzed so deeply. What I think you are seeing is some triaging of exactly what is going to be top of mind for folks at any given time. So you have from the payer's perspective, for example, you have a requirement that's coming up quite quickly for them to provide access to patients. You have a further requirement down the road for payers to exchange information with one another. And obviously they're aware of that, and I'm sure they're giving it some mind share, but at the same time, that sort of has to be put on the back burner so that they're able to meet their more immediate time constraints. And I think you'll see some of that across the industry as folks try to balance how much they're biting off at any one time.
No, all very good points, and it's, it already seems like we're having some kind of consistency and themes emerge from what each of you were saying. The primary one being that this is going to be, and I think in the words of John, a journey that's going to take time to work towards particular goals and places along that road. So kind of thinking about the fact that it is a journey, I think it would be helpful to start diving into, what are some of the specific steps or infrastructure that's going to need to be both modified and put into place as, organizations, whether it be physician groups or payers, have to start paying attention to. And with Chris being the first-time panelist for an Answers Media Network discussion, I'll let him lead off this part of the response.
All right, jump right in. So overall, we have two major rules: the CMS Interoperability and Patient Access Rule, and then the ONC 21st Century Cures Act Interoperability Rule. The easiest way to divide them up is that the CMS Interoperability and Patient Access Rule primarily has compliance obligations for hospitals and health systems, as well as insurers or payers. And then the ONC Interoperability Rule pretty much covers everyone in the healthcare community, including physicians. From my perspective, as I mentioned, most of my work is done on the physician community side. So ultimately, the CMS Interoperability and Patient Access Rule ends up really being more of a positive on their front from a compliance perspective, because they don't have to do anything, and yet they can potentially be on the receiving end of admission, discharge, and transfer notifications from hospitals they might be working with, as well as some information on the patient side through what the insurers are required to give to their patients, and ultimately in the value-based care networks, information that might empower their patients to be more active in their own care that's delivered on the ambulatory side. With that being said, there are, not only in addition to the technical infrastructure that needs to be in place within these large organizations and just how sweeping and long and complex these regulations are, internally within organizations, there are efforts underway to put together, working groups, multi-stakeholder groups to actually educate and understand within an organization ultimately what they have to do, what they might have to build, and the compliance timelines that they have to meet throughout the future. So I think those are a couple of the insights from my perspective. But again, on the overall impact, through my work, it's mostly on the ONC rule. So I'll defer the rest of my time to others on this one.
Dave, would you like to weigh in next?
Sure. Yeah, I think the question on what infrastructure is going to be needed is really an interesting one. There's certainly at a most basic level, that there obviously is a technical infrastructure that's required, and the fact that that's obvious doesn't mean that it isn't something that folks still have a challenge with. Not every organization that is required to provide patient-facing APIs, for example, that are publicly accessible, has in fact done so, and so that's something that they're going to have to look at doing from a technical standpoint. And that's reasonably straightforward to do in the grand scheme of things, but at the same time, if you're doing it on a short timeline and depending on what your COVID obligations have been, that can still be a challenge. Chris is certainly right in that it's almost hard to talk about all these things because there's so many moving parts and pieces, and there's the CMS rule, and then there's the ONC rule. Certainly with respect to the ONC rule, there's some infrastructure that you might not think of that's required in the sense of needing to do a lot of documentation of policies and procedures and making sure that you're not doing things on a one-off basis, or you're avoiding that as much as possible, because it's really challenging to sort of wedge yourself into one of the exceptions if you don't have documented policies and procedures that you're following. From the CMS rule perspective, though, to circle back to that one specifically, one of the pieces, and I mentioned this briefly earlier, is the not immediately impending, but nonetheless upcoming requirement for interoperability between payers, and something that they haven't seen yet. I think, I try to avoid self-promotion on other people's webinars as much as I can, but I think there's an interesting potential there for the Cure Equality framework to help payers in the infrastructure that they need, because they are going to need some sort of governance infrastructure, whether it's Cure Equality or something else, that will enable them to have a sort of implement once and connect universally paradigm with other payers. And that's something that they shouldn't be taking lightly, because if you try to just do one-off connections with every other organization, it's obviously not going to work.
So, John, would you like to weigh in?
Yeah, I think that as you think of the technologies that are going to have to be there underlying the facilitation of patient information, both for patient access as well as notifications, as is in the rule for ADT, and certainly just the continued push forward for general interoperability. I think you've got a number of folks who have deeper pockets than others that are in a better position to implement more sophisticated and I think more immediately compliant with the rule kinds of technologies. At the same time, you have parts of the overall healthcare landscape that are going to struggle to be able to do those things, to be able to facilitate these kinds of communications. And I think that to a great extent, while HL7 Fire and direct secure messaging are clearly the leading candidates for the kind of interactions and exchanges that need to happen, when you look at areas of healthcare generally, and the post-acute world comes immediately to mind, as well as when you get into single practices, especially as you get into rural areas and areas that could be impacted financially in urban areas, this starts to be more and more of a struggle. So I think that we have to think about the rules, the implementation of the rules, and the practical reality of how the communication is going to work day one, with an eye towards I'll call it the parts of healthcare that are more economically challenged to meet compliance measures, and offer some kind of bridge to be able to get them from where they are, how they find themselves, to where they need to be in a reasonably low-cost way, in a way that is not too disruptive from a technology point of view. And I think that's a big focus of what needs to happen as you think of the full universe of healthcare.
Yeah, and Matt, the only thing that I would add is maybe focusing in on kind of the education component, both for clinicians and for patients. that they fully understand what the rules say, what the rules require, and also what happened, what is the kind of the conditions around a patient moving their data out of a HIPAA regulated environment to kind of a third-party app environment that has different regulations around it. So I think that the education component is, in addition to everything that was already said, I think is an important piece that needs kind of full consideration as we think about infrastructure concerns.
Yeah, and Jeff, your comment about education anticipates something that was coming to mind as John, Chris, and Dave were describing all the complexity between the two rules, which is, it seems like there is going to be a lot of opportunity for misapplication, misunderstanding, or just lack of awareness. So is there a feeling that there could be, unfortunately, kind of widespread non-compliance just because it's too difficult to learn all the details of the two rules? And Jeff, I'll let you kind of lead off with this one since this ties into the point you were just making.
Yeah, I think that's an interesting question. I would say that in general, organizations are laser focused right now on trying to best address COVID-19. So I think you can almost think of these rules being finalized and kind of the COVID-19 pandemic here, public health emergency here in the U.S. almost began kind of concurrently. So I think that attention has unfortunately shifted away from implementing these rules to trying to make sure that patients are being treated and that COVID is being addressed in different healthcare systems, different facilities, et cetera. But I do think that there are a lot of opportunities in terms of what you were just talking about related to kind of better education and making sure that folks are setting themselves up for success underneath these requirements. In terms of the enforcement discretion that ONC and CMS granted, in April, and I think that, again, as we've kind of alluded to, I think we'll see additional enforcement discretion very soon from the agencies in terms of some of the requirements. But I think that what they said was organizations that are able to continue implementing these rules and beginning to more broadly share information should continue doing that. But obviously, ONC and CMS and HHS writ large have recognized that the focus really needs to be on addressing COVID-19 for the moment.
Yeah, no, I think that's a great point. It's COVID has rightly taken almost all the attention across whatever kind of component of the healthcare industry you're thinking about. But Chris, let's go to you in terms of what you think about in terms of around what we could see in terms of levels of compliance.
Sure, I would agree certainly with everything Jeff just said around the imperative of COVID right now for different organizations and really the focus that they have and their employees have. And I think when you think about the training that will go in and education that will go into ultimately having employees be able to understand these rules and the requirements enough to be able to comply with them, the last 6 months they've been dealing with all sorts of new training on any host of issues, from PPE on down the line of things that they've never really probably thought about in as much detail as they've been forced to the last 6 months. So I think it's going to be tough to get them to a position where they have, that people who are overly busy working in the healthcare community, where they have an hour at lunch on Tuesday that they, have for training every couple weeks, and that they're going to be able to devote that to these rules as opposed to something COVID related or another initiative that they have been focused on in the past.
Dave, how about you?
Yeah, I mean, I think that everything that Chris said was true for sure with respect to COVID and education. I'm hopeful that there won't necessarily need to be as much education of the frontline staff. I think that would be an unfortunate burden if that needed to occur. And there certainly may be some areas where folks need to ensure that physicians are aware of when not to take certain steps that might be information blocking, for example. But I think a lot of the burden is going to fall on back-end staff, whether that's the medical records team, the legal team, certainly the IT department is going to have to be doing a lot of work in conjunction with legal and privacy and others. So it's an interesting question. I think sort of getting to I think a little bit of the spirit that was behind your question and whether there would be widespread issues with compliance. I think even though the rules are quite complex and broad, as we've said, the spirit of them is, I think, relatively easy to discern. So I think that folks will be making good faith efforts that will align with the spirit of the requirements. I do think that there will be, I think, a lot of what I'll call incidental in the non-compliance, if that makes sense, just while everybody kind of figures out how these are being interpreted and how my good faith interpretation bumps up against what ONC or CMS actually expected.
And John.
Well, as I spent a number of years working for Glenn Tillman at Allscripts, and he always had a saying, which is, you don't have to memorize the detail of what you understand. And to build on what the panelists have been saying, it's about understanding the spirit of what's being implemented and why it's being implemented, and the positive effect that this has on healthcare in general. The place where I think it meets some potential for disruption at the front line, especially given the work that so many of our frontline caregivers are doing in the COVID pandemic, is where you are implementing changes that are going to impact workflow, and incorporation of that workflow into something that's already sort of automatic muscle memory for the providers that are giving care during the pandemic, to have to disrupt that, put in place different ways of doing things, and to be able to do it in a way that is compliant. And specifically, going back to the effort that's going to need to be put in place to change so much record keeping from paper to electronic. And I know that generally you look at healthcare and think, well, everybody's got an EMR, but in reality, when you're looking at those places outside of acute and ambulatory care, those places that have long been practicing on paper, and the kinds of things that they're going to have to do in order to reach compliance in spirit and in fact, is going to cause some potential disruption to their ability to do what they do day in and day out. I think support in those areas is what has to be kind of front and center, as you've got the large part of the healthcare IT community who is used to living in this environment, able to execute with a different kind of precision than a widespread swath of the healthcare community that simply hasn't adopted these tools and now is getting forced in a much more real way to go down that path in a relatively short period of time.
Yeah, and John, kind of picking up on what you were just describing in terms of putting new practices into place, I think this is actually a great way to go back to one of Jeff's opening points about how it intersects with existing regulations. Because I think questions have already started arising. Is there misalignment or even tension between some of what these new rules are calling for, and in particular the immediate example that comes to mind for me are the information blocking and the scope of access and either real or perceived tensions with HIPAA requirements. So kind of I guess breaking it into the two pieces, I would be interested to hear from all of you if you do think there is that tension, and regardless if you answer yes or no, how do you move forward to, hopefully put into practice a cleanly reconciled operational model that respects all the requirements. I know those are very loaded questions, so I'll put Dave stand first.
Excellent, thank you. I think you used a word there that was important in perceived and perception. I think the ONC and CMS did a good job of trying to be clear, and I'm especially thinking of the information blocking exceptions here, that compliance with regulation, existing regulatory structures, and with applicable law in general was okay. That you're not being compelled to release information that you aren't permitted to release. But that gets into the fact that we still have some lack of clarity on some key elements within even HIPAA compliance. Once you get outside of the treatment realm, for example, and minimum necessary starts to kick in. Well, okay, what does that actually mean? How do I parse minimum necessary relative to the requirements to make the US CDI available? What does that actually mean to me? And I think you will see some differences in interpretation there that need to play out. And then, but otherwise, I think in terms of the letter of the law, they've tried to account for it. But again, where there is existing ambiguity in certain key areas of HIPAA, that's just going to be magnified by these new requirements.
So, Jeff, I'll let you jump in next since you provide the impetus for this.
Okay, maybe that's a good thing, but I think. I think that often our medical system has been somewhat paternalistic in nature, and I think that docs and clinicians in general, have had genuine concerns about patients and control of patients' data, and worried about when that information moves outside of a HIPAA-regulated environment, given a lot of the cybersecurity concerns that are really out there. So I think that what ONC tried to say in their rule was that clinicians can bring to the attention of patients whether a third-party app that a patient may be using is and receiving their electronic health information can attest to having privacy and security policies and practices that meet industry standards. But I think the rule is as a non-attorney speaking, I think the rule is pretty explicit that a clinician can't say that a patient can't take their information and transfer it to this third-party app, even against the recommendation of that particular clinician. So I think it goes back to the patient education component. What are the other means that a clinician can use to kind of educate patients on what happens to their information when it is more broadly shared outside of the kind of traditional healthcare HIPAA regulated environment.
John, I'd like to get your thoughts now.
Yeah, I think that it's crossing a threshold from the healthcare environment that is regulatory with HIPAA controlling to an environment where privacy is not necessarily statute enforced, right? So making choices personally on the level of comfort with privacy policies of the third-party app, or even decisions to say, I want to download this information onto my PC and have it exist in a file structure, starts to get to questions of personal comfort with the level of privacy for your information, and the kinds of things that I think start to get outside of the regulatory environment within healthcare. And those are tough questions. because once it does leave that regulatory environment, once it's in the hands of the patient, whether in that third-party app or whether it's something that the patient has put onto some sort of media other than that app, it starts to get very difficult to try and figure out how do you regulate that in a way that isn't infringing on a person's freedom to do what they want with those records. And I think secondarily is that since this access to patient records is sort of a raw access, the number of providers who I've spoken with, there is also a bit of a concern that the information and notes, the way that providers assess patients, the way that they write their observations has to be, in a sense, not necessarily fit for consumption of that patient consumer. You're going to have the clinician in their assessment, in their notes, and in the kinds of records that patients will be able to access, be brutally honest physicians to be able to be medically focused on what that patient's condition may or may not be, and the steps that you need to take, and those kinds of things can sometimes be an area of concern for physicians in sharing that information directly with a patient in an unvarnished way.
So, and Chris, your take?
Yeah, I think certainly this is a key issue and one that a lot of different stakeholders have weighed in on as the final rules have been released, because it is quite controversial around, essentially having these APIs built where data is protected within the EHR or whatever the protected format it might be, and then an API enabling this data to go to a third-party app with patient consent that would then be in an unregulated environment from HIPAA. And that this is really the driving force behind so much of the law, and yet it sort of creates this potential problem down the road. And ultimately, I think we'll have to see, obviously, how it plays out in the real world, as they say, and not in the theoretical, to see if it does become something where there's a problem. But I think it also will be interesting to see how Congress and how the world of DC, treats this issue over the next few years, because even as the rule is being finalized, it's something where in Congress there are discussions around, filling those gaps around where HIPAA does not cover these third-party apps and creating new legislation in those areas. And I think when you combine that with whole other areas to look at outside of healthcare, data within the big tech world, and in what ways is it regulated, and where's the role of privacy and the government's role as a federal regulator, I think it'll be a very interesting discussion over the next few years.
And I think all of you were kind of referencing that fact that, you're going to have these outside applications connecting in, and those outside applications don't necessarily have to fall or comply with healthcare-specific regulatory schemes. Kind of, Chris, to the point you were just making around that, arguably that scenario exists already today with the right of access, because, under the right of access, an individual has the full ability to direct their clinician or organization to send information how they want it and where they want it to go to, which is, I know that's always a concern working with organizations, because, you worry what can happen to that data once it's in an arguably non-secure location. So kind of, I think building off of that, do any of you think that there might be efforts from within the healthcare industry to engage with those, call them non-covered solutions, to have either best practices that can be voluntarily followed when it comes to privacy or security, or taking other steps to really help promote better privacy in the absence of some type of legislative or regulatory solution? I will let John lead off on this one.
I think that there has to be a partnership that evolves between the leading vendors who create these third-party apps, or even, current IT, health IT vendors that create them with an eye towards exactly that kind of security. I think what'll emerge is a number of partnerships around there, or a number of direct written access kinds of applications that you're going to see from the EMR vendors or HIE vendors that are on the market. I think that you'll probably also see a portion of the vendors who write these as being ones that are, opportunistically looking at being able to create some economic advantage for themselves and not necessarily be from inside the industry. The hope is that as these are put forward, that you'll see the more healthcare savvy professional developers be at the forefront of this, and I think that was a lot of what was being attempted with the blue button initiatives to make sure that not only were people being prepped for writing to an API that was going to be able to allow patient access, but also an education process in that the participants would be exposed to being able to understand the environment in which they were writing these kinds of apps and the importance that privacy plays in being a provider of an app like that.
Yeah, no, I think very good thoughts. Chris?
I think an interesting analogy to think about on this particular issue is if you think about the meaningful use program and the incentives that were to put in place to adopt and digitize health information in EHRs. And then on the back end of that, there was a lot of frustration throughout the healthcare industry that ultimately came through Congress around the lack of interoperability between those digitized systems and the investments that Congress put into this program. I think here, possibly similarly, you have through the APIs and all of these rules around interoperability, you have Congress essentially establishing a system by which those EHRs and other actors in the healthcare system are required to share information digitally with other actors. But as part of that, I think no one wants that information to be used in an incorrect fashion or in a way that's not protecting patient privacy. And I think as we saw with interoperability, everyone knew that was a big issue and was focused on it way before the Cures Act passed into law. But ultimately, Congress was unwilling to wait for that to happen and for the various different private sector initiatives that were underway to come to fruition. And I think here we potentially could have a similar issue where you have multiple different initiatives that will likely be underway. And I certainly agree to your original question, Matt, that there will be different private sector initiatives to protect this data within these third-party applications. But I think the question will be, will there be one big story that the media runs with that Congress gets a hold of and passes a law, or will they wait for the private sector to figure it out? And again, I think on interoperability, clearly that did not happen. We'll see on this particular issue if it's something that will happen over the next few years.
Yeah, no, and Chris, that's a good point of, oftentimes the private sector can be given that opportunity, but if, a particular angle or a particular issue gets a lot of media attention, then it almost becomes inevitable that you'll have legislative action because the legislature might feel that they're either getting complaints from constituents or that it's such a hot button issue that it's an easy one to be able to tackle and earn political goodwill with. But kind of going back to the initial question, Dave, would like to get your perspective.
Yeah, there certainly are things that the industry is doing that we could lean on in this area around certification of apps. I don't know if anybody has actually finalized a true certification program, but certifying against a set of norms around good behavior is certainly out there. I know that there's a lot of work that's been done by the Karen Alliance. Not that they're necessarily unique in putting work in this area. It's an effort that I've had an opportunity to be involved in personally, and they've actually developed what they call their code of conduct, which is voluntary, and you can, as an app developer, attest that you have that you are in compliance with that code of conduct. And where that really plays in, I mean, there's a certain amount of enforcement that then kicks in from the FTC if you claim to a consumer that you are abiding by that code of conduct. exactly what the teeth are in relative terms compared with the teeth for HIPAA and healthcare providers is a different question. But there is at least an enforcement mechanism that kicks in there. But then that also gives the ability for others to sort of take those requirements and run with them, to in fact use those as the basis for certification programs that they might deploy, as I referred to earlier. And then ultimately it becomes a matter of patient education, as several folks have stated already, where it gives you a concrete element that you can point to as a provider organization to say, hey, look, you have a lot of choices out there, but here's one way that you could consider trying to make sense of them. Look for this badge, look for this certification, if you will.
And Jeff.
Yeah, and to me, this goes back to the point I think Dave originally made around, what's the spirit of the ONC and CMS regulations? What's the spirit of 21st century cures? And that is the patient firmly in control of their information, directing their data to entities, to other providers, or to third-party apps, at their discretion. So I think that organizations have to figure out how best to get information in the hands of patients in the most expeditious way as possible. I think that there, as Dave also mentioned, Karen Alliance, I know has done a lot of work around a code of conduct for these kind of third-party apps. So I think efforts like that will be critically important as we move forward with some sort of broader privacy legislation. And I do think that a lot of folks in Congress and next year will raise kind of broader privacy concerns beyond healthcare. So we could be looking at issues beyond healthcare that I think obviously touch on healthcare, but a new kind of way to kind of think about personal privacy and allowing patients to and just individuals in general to know exactly where their data is being shared, who has their data, who's accessing their data. Those are, I think that's the direction that a lot of patient advocates in particular and a lot of privacy experts are headed.
Yeah, no, Jeff, I think you raise a good point about the broader privacy perspective in picture, and while kind of legislation has gotten derailed at the moment, I think you're right that next year, after we're past a presidential election, hopefully Congress will turn its attention back to that, because arguably a much broader and comprehensive privacy scheme is really necessary, so that way you don't have the patchwork of states, and you can fill in the gaps that I think all of you have referenced at various points throughout the discussion. So actually kind of thinking about those privacy considerations, and also maybe backing the conversation up a couple levels, all of you have referenced the spirit and the intention of the interoperability regulations. I think probably to some degree the answer to that, what that spirit is, has come out, but I think articulating what that spirit is now, I think would be a helpful way to kind of further elucidate the various points that have been raised. So Jeff, would you like to start us off with that piece of the discussion?
Yeah. I think the other phrase that I often come back to when I'm kind of describing what the ONC and CMS rules really mean to consumers and providers is is the phrase that that's I think used multiple times in the ONC regulation, and that's about minimizing the special effort for providers and patients and to access, exchange, and use electronic health information. So I think that is, it kind of embodies everything that we're talking about. There have been instances where interoperability and data exchange have functioned well across the entire healthcare ecosystem up to this point. But I do think that there have been challenges, as most folks can probably attest to, around maybe roadblocks and that different organizations may have put in place, whether they're concerned about transferring data outside of their four walls, or there are other organizations that again may have this kind of paternalistic viewpoint about broadly sharing data with unknown entities. So I kind of come back to that special effort, minimizing the special effort phrase a lot when I'm kind of describing what's included in the rules.
Yeah, no, very good point. John.
Yeah, and I think building on that, it becomes incumbent on the industry that is supporting healthcare to see what we can do to pave the path. In my opening comments, I talked a little bit about this being a journey, and that if past regulatory kind of changes in healthcare have taught us anything, you don't throw a switch and immediately have compliance, because people do need time to get from here to there in a simple way. I think the spirit of the law and the idea that a patient is in charge of their records, and we want to be able to ensure that we're exchanging information at critical points in a patient's care journey, as well as making sure that we do those things simply, is an important consideration as healthcare IT vendors think about how to facilitate that in a way that is inclusive of the full spectrum of healthcare providers, and make sure that we're taking steps to not only comply, but to be able to help our, ultimately the folks who use our tools every day to be able to deliver care, to have them, take these steps and beyond this journey in a way that is as simple and as undisruptive as possible.
And I think very well stated. Chris.
Yeah, I'd say, well, first of all, it's difficult sometimes, and I'll say I lose the spirit of the regulations sometimes. When I pass the 1,000-page mark in reading them, it can be tough to keep through it, as I'm sure some others on the line will have. But I think these rules do many different things, and they impact really and touch on all different stakeholders within healthcare, from hospitals to insurers to physicians to IT vendors to HIEs. And there are multiple different compliance obligations, and information blocking is just one of them within the rules. But I think the real spirit behind it comes back to, all of those actors, when you have either a patient or a participating provider who's working with a patient and they need a piece of information, don't block information. And the rules are very complex. Information blocking is a very difficult thing to wrap your head around, no matter who you are. And, with the different exceptions beyond it, and generally, even if you have the technical capability to share information, there are, exceptions and other rules that apply around how much you might be able to charge to enable that, or, other sort of, ways around it, or different qualifications around the standard. But I think really the spirit behind the law, and what ultimately they'll be enforcing years from now, is if you have a patient or provider who wants their information, you can provide that access to that information. Don't block that information.
Yeah, Dave.
Yeah, I would agree with Chris. I think he stated it well, and I think the structure of how ONC approached information blocking is informative in this area. Basically, they said anything that interferes, and obviously I'm paraphrasing, but anything that interferes with the access and use of information is information blocking, and it is against the law. And here are the very complicated at times exceptions to that obviously we know that there have to be, but they started from the standpoint that you absolutely cannot block information ever. except where we say you can. And they made those exceptions, I think, relatively narrow in many ways. I mean, you can argue that some of them are very narrow and some of them are much broader, and there are ways that you can probably figure out how to fit some different practices in there. But at the end of the day, you are expected to share information. And I think it's worth noting, I think a part of that and why they came around to it was sort of increasing frustration as they looked at what they thought they had required before. For example, specifically the HIPAA right of access, I think arguably is not necessarily seeing full compliance today, and I think that's part of why you see the information blocking and the other focus, and even in the CMS rules, on ensuring that there is patient access to that patient's own information.
Yeah, no, thank you all for, as I said, kind of allowing us to back up for a minute to re-level set in terms of what's meant by the spirit, and with all with the. I think all of you giving a great description of that, and it, all going in the direction of, the basic premise is we want to make data accessible, we want to make it flow. That seems to be kind of feeding into a narrative that I've been observing over the past few weeks, or recently, that interoperability is kind of being touted as the solution to many of the ills within the industry. And my fear is that that's setting it up for failure by putting it on too high of a pedestal. So would be interested to see if there's agreement with that thinking, or kind of where you think the discussion around interoperability is going. So Dave, would you like to lead us off on that discussion?
Sure, and in our preparation for the session, you have some sample questions that you thought that might come up in the conversation. One of them was about the hype cycle, and actually, I think that the way I thought about the hype cycle merges well into that question. I would agree with you that there are some potential unrealistic expectations for exactly what patient access in particular is going to enable. I think, folks, on the one hand, yes, you absolutely, for its own sake, sort of as a policy goal, we want to ensure that patients are empowered and that they have access to their information. But there's also a very clear secondary expectation there that the information won't just stay with the patient, that they will be able then to provide it to others, that they can maybe broker exchange of information in ways that will bypass some of the issues that we've had in interoperability between these existing stakeholders with the patient there. Now, all of a sudden, the information is going to be able to flow with the patient as the broker. I think there's some reason for optimism that might in fact occur. Will it occur as quickly as people are hoping? No, almost certainly not. But, that's just healthcare interoperability timelines in general. The other aspect of it, though, is what's the motivation of the patient to actually play that intermediary role? It's not always clear that the patient is going to want to do that. I think there are some areas where patients are going to play a role. People are going to come up with compelling user interfaces, and they're going to make the patient an offer that the patient wants to take up. There's value to me as a patient in being able to perform some function that maybe has a secondary effect of providing information to other parties as well. But otherwise, there may be some of these problems that we want to try to solve in terms of getting information between existing stakeholders and breaking down barriers, that there just isn't a compelling role for the patient in there, and we may find that those still lag a little bit.
Yeah, no, I think that's a great point. It's there's going to be a lot of hopeful room for personal preference and personal drive in there. John, what's your perspective?
I think that building off that is the idea that a patient is going to be as involved in their healthcare as that patient will be. I think that the reality is that outside of patients who have chronic conditions or patients going through an acute episode, there isn't necessarily a ton of overwhelming involvement with patients and their healthcare. And I mean that as you look at some of the initiatives done by large IT companies like Google and Microsoft to have patients take an interest in and be the center of their healthcare. The reality is that in healthcare there is no silver bullet. Giving patients access to this information, you're going to have some patients that are very engaged. You're going to have probably a lot more patients that aren't terribly engaged. And I think that while you're going through the process of removing this hurdle, which is an important hurdle to remove, that the panacea of healthcare improvement by the act of doing one thing and finding that silver bullet is a fallacy. It's just going to be a continued process of, okay, now that we've put this obstacle over here, now we can turn our attention to the next obstacle or the next two obstacles to try and get us further and further down the road. Advancement, absolutely. A step in a direction that improves healthcare, yes. An answer in and of itself, it just isn't.
Thank you. And Jeff?
Yeah, I think the way that I think about this question is maybe to even get a little more broad in terms of where we want to go, and I think the idea of moving to a broader system of value-based care delivery, I think would support interoperability, would support would solve a lot of the other issues that we have across the healthcare ecosystem. So I think interoperability is obviously important, but I think about this as if we were to fully implement and head more firmly in the direction of a value-based care system, I think paying for patient outcomes versus the volume of patients that we see, I think that would have the sense of supporting broader interoperability, because I think information will be required to move in order to treat patients in kind of this new delivery system. And I think it would solve a lot of the other ills that we have across healthcare.
I think, as everyone so far has said, it's a stepping stone. But Chris, I don't want to preempt any of your comments.
Yeah, so I'm very optimistic about many of the initiatives that are already underway and have really been underway for several years, led by the private sector and really in partnership of different organizations and different competitors, frankly, within the industry, who have been pushed for a long time to deliver this interoperability. And I think that the rules will provide, as you said, some kind of a stepping stone towards at least providing the capability for empower patients, I should say, who want to take control of their data and use it or manage it in whichever way they want. But at the same time, I'm very pessimistic about the ability of these regulations to deliver the silver bullet that I think many have been counting on over the years. And I think that because they've been such a long time coming, again, I mentioned earlier that the law was passed in December of 2016, the Cures Act. It took several years before that where Congress was holding hearings and drawing up support for the provisions in the law. We're just seeing those provisions, the first of them, implemented largely in 2020, 2021, and it'll be a few more years before they're actually rolled out throughout the industry. I think the issues have changed, technology has changed, the industry has changed. There is a workable framework there that can add to the conversation. But I think for those that have been waiting for these regulations for years now to deliver, the silver bullet that accomplishes interoperability, I think they will be disappointed in that manner.
No, and I think that's a great point, and I think was repeated by all of you, that clearly this is not and cannot be a silver bullet, because that just is kind of that mythical creation within the healthcare industry. But what all of you were also saying is, it's part of a larger systemic movement in a positive direction. And I'm kind of very intrigued by something that you were saying, Chris, which is, you're seeing more industry collaboration and coordination among organizations that were potentially historically competitors. So do all of you see that continuing to happen, and do you see the silos that have been created by wanting to hold on to a particular market share continuing to break down and allow for really true kind of cross-pollination and intersection. And Chris, I'd like to have you lead it off, since I was kind of basing that off of your last comment.
Sure. Well, I come from the spirit of EHR vendors collaborating with one another. In my previous role at NextGen Healthcare, I led the EHR association with the other vendors and their public policy efforts, and actually dating back to the point in 2014 through 2016 where they were working on passing this law. So I had to be very involved in those conversations. And you've seen, I think, since that point in these 5-6 years, multiple different private sector-led initiatives that really, maybe they were done with the prospect of these rules coming down a few years later, but they were certainly done on their own without these rules being the driving factor. And I am optimistic about what they will mean for the future. And even at a minimum of, what these rules and the information blocking rule will enforce in the future is some sense that, one actor cannot hold back nationwide interoperability at whatever perspective they might want to be for their own business interests. And I think if nothing else, the rule and that information blocking final regulation will have accomplished that, 10 years from now, if we're looking back.
Yeah, no, and I think that kind of a little bit more of a background into the negotiation and input from the industry just for the 21st Century Cures Act itself is very informative. John, what about your perspective?
Yeah, I think that industry collaboration is certainly something that we've all had experiences as something that's taken root in a very meaningful way over the past several years, and I think there are a number of initiatives from the vendor community. There still, I think, is a role for facilitators to step in and help with communication in a way that can I'll say play Switzerland and be able to effectively ensure that information going from point to point and how it gets there in a way that is as much as possible a buffer between any potential competitive concerns of how that information sharing may or may not open up some kind of competitive advantage for one or more participants there. I think that those roles are still an opportunity in healthcare IT generally. And I'd also say that depending on who the competitor is, who the provider is, there are certain members of the HIT community that tend to be a bit more closed in terms of the kinds of network participation that they choose to engage in. Hopefully that this continues to help thaw that so that we get increased collaboration. But I think in general, when you look at the industry, the what I'll call the co-opetition aspect in healthcare IT is certainly one that I believe as you look across the entire landscape of business in the U.S., this is one where you tend to collaborate more than you do in others, simply because of the nature of what you're working towards, which is ultimately the delivery of quality care at the point of care and being able to facilitate that.
Yeah, no, I like that idea of a facilitator and having, having someone hopefully trying to advance the ball from that perspective. Jeff, I'd like to get your thoughts.
Yeah, I think when I think about collaboration, the first thing comes to mind is that it's a good business practice to figure out how to best position your organization to succeed and kind of under new market conditions. So, I think that there is a lot of collaboration that's happening across all healthcare stakeholder organizations, and those are the organizations that are I think better positioned to share information, to abide by the spirit of the ONC and CMS rules. So, and I do think that there is also a component in terms of what patients are asking for and what patients are demanding. You know, we often come back to the line and kind of help IT about how, you know, patients can, you know, move their banking and financial information across different apps and across like different platforms. And why can't you do that in healthcare? So I think that there is, you know, kind of that impetus as well in terms of thinking about how you can position your business to better serve the needs of your patients.
Yeah, no, I think a good thought there as well. And Dave.
I've seen, you know, competitors working very closely with one another. You know, they compete like crazy in some areas, but they're willing to come together in these forums, and I think that does predate the rule, and to a certain extent may be anticipated that there was going to be some action if they didn't get their act together. But really, I think stems from, for the most part, wanting to act in good faith. You know, so you see Epic and Cerner on calls together, working very collaboratively, and you see, you know, big national payers who compete like crazy doing the same thing in the appropriate forums. Where I think the rules can play a role in this area is in taking all of those who maybe were on the periphery. You know, John has talked a few times about different parts of the industry like LTPAC and others where there just isn't as much participation in some of those efforts, and spurring the late adopters to move along and sort of align with where some of those at the forefront of the efforts have gotten to voluntarily. It's sort of coming up behind the industry, if you will, and bringing those late adopters along. Now, there are some other areas of the rules where they're clearly trying to lead and get ahead of where things are, but those areas where they are, I think, sort of bringing everyone up to the same standard is really beneficial, and it is a good interplay, at least in my opinion, of private sector efforts and regulatory efforts.
Yeah, no, and I think that the message that all of you gave of that there is a lot of collaboration already occurring, and that has been occurring for years now. It does offer a lot of a lot of promise, hopefully, for where things are going in the future. But you know, this has been an incredible discussion among everybody, and believe it or not, we're already at the end of the time for that discussion. So it's, you know, I think leaving on that final message of collaboration has been and is occurring is a great way to be able to part ways, at least for the moment, and probably just until next year, because I'm sure this discussion will continue. You know, so John, Chris, Jeff, and Dave, thank you so much for sharing all of your thoughts and perspectives.